So our group Sibling and Lynette and Tasha Travers will present asthma and COPD. Okay, we'll start with asthma. The definition, asthma is a long-term condition affecting children and adults. The air passage in the lung becomes narrow due to inflammation and tightening of the muscle around the small airway. This causes asthma symptoms such as cough, wheeze, shortness of breath, and chest tightness. And these some common symptoms: chest tightness of pressure, difficulty in breathing, wheezing while the patient exhales as a whistling sound, shortness of breath after exertions, dry cough, cold that quickly moves to the chest and is symptoms that linger. And let's move to investigations. The golden investigation is a spirometry. Because it's more reliable than peak expiratory flow. This should be carried out by trained personnel using well-maintained and calibrated equipment. And next is the peak expiratory flow measures. Peak flow monitoring over 2 to 4 weeks. Calculate means variability. The daily diurnal PF variability is calculated from twice daily, and peak expiratory flow as height. Days highest minus days lowest and divide by means of days highest and lowest and average over 1 week. Variability more than or equal to 20% or diurnal variations more than 50% on more than 3 days per week indicate a positive test. And next, go to the acute asthma. What is acute asthma? Acute asthma is progressive or sudden onset of worsening symptoms such as shortness of breath, chest tightness, wheezing, coughing, and the early recognition can prevent morbidity and mortality. And for the assessment, history and examination should be performed along with the initiation of acute treatment, such as time of onset, severity of symptom, current treatment, risk factor of asthma-related death. And next is the sign of severe exacerbations of the asthma is the patient will sit forward and speak in word or short phrases, use of axillary muscle, agitation or outer consciousness, tachypnea, tachycardia or hypoxia or silent chest. And this table shows the level of severity of acute exacerbation of asthma. There's 3 types of severity: mild to moderate, severe, life-threatening. For mild to moderate, the clinical features is speak in phrases or sit up, not agitated. And the clinical parameter, the respiratory rate is 20 to 30 per minute. The PR is 100 to 120 per minute on O2 saturation 90 to 95%, and peak expiratory flow is more than 50% predicted. And for severe, the patient will speak in words, sit forward, agitated, accessory muscle is used, and the respiratory rate is more than 30 per minute, and the PR is more than 120 per minute, and the O2 saturation is less than 90%, and the peak expiratory flow is less than 50%. For the life-threatening, there is considered severe asthma with any one of the following: is drowsy, confidence, exhaustion, cyanosis, hypotension, silent chest, or poor respiratory effort, or the peak expiratory flow is less than 33%, and the PaO2 is less than 60 millimeter mercury, or the normal or rise PaCO2.
Okay, so I'll be continuing on the aim of treatment.
Let's stop here. Let's just go to the slide.
Which one?
Just go back to the initial slide. Let's just go through one by one. Okay, so asthma. So in your first, second years, did you guys learn about the pathophysiology of asthma and all the rest of it? Okay. So so basically, asthma is a condition where there's chronic inflammation of the airways. Yeah. So airways meaning that your trachea, bronchus, bronchioles, and so yeah. So basically, asthma is a condition where there's chronic inflammation of the airway. So your airways, your bronchus, your bronchioles, and everything has a specific diameter. When patient with asthma, they have this chronic inflammation that causes the diameter of the airways to be narrowed. normally in normal situation it wouldn't cause much problem. They have narrower airways than normal people because of the ongoing chronic inflammation. However, when they have an acute exacerbation or something that triggers their asthma, the already narrow airway will close off easier, because the inflammation, whenever they have an exacerbation, the airway tu, which is narrowed by the inflammation, the mucosa of the airway become edematous and whatnot, if you can imagine lah. So the airway is like this, kan? Then you got edema, inflammation going on in the inner diameter of it, and as we breathe, inspire and expire, as we breathe out, the airway does become narrower, because air is pushed out, kan? So with asthma, because of the inflammation, when the airway narrows in expiration, it closes off because the diameter is small. Macam normal people, they have airway macam ni. So when they expire, the airway become narrowed, but it doesn't close off. There's still hole, kan, for air to go out, the CO2 whatever to go out during expiration. However, when patient with asthma, you imagine the airway is the same size, but they've got mucosal inflammation in the inner diameter of the airway. So when they expire, the airway become narrowed, tapi because of the inflammation, the hole will close off lah. So you got air trapping in the lung. So these narrowing lah yang cause your wheezing, your rhonchi, kan? When you listen to patient with asthma, patient with exacerbation of asthma, when you listen to their lungs, you'll hear wheezing and rhonchi, all these end expiratory punya sounds. That's why classically asthma punya sounds is described to be at the end of expiration, because that's when the airway become narrowed, and as air pass through these narrowed airways, it will make this characteristic sound. So if you baca your textbooks dan sebagainya, the characteristic description of rhonchi or wheezing ini is a musical high-pitched sound at the end of expiration. It's because when you expire, the airway become narrowed, and because of the underlying chronic inflammation, the airway is almost closed off lah. So that's the mechanism of asthma. So the thing about asthma ni, it's if you imagine, it's like having a chronic inflammation ongoing, and then you got acute, whenever you've got an exacerbation, you've got acute on chronic inflammation going on. So the narrowing become worsen due to whatever triggers that trigger the exacerbation lah. It can be infection, it can be just ILI punya symptoms, it can be cold weather, it can be allergies, and anything, stress, exercise. These can trigger the acute inflammation on top of the chronic ones. So then you get acute exacerbation of asthma. So bila bercakap pasal acute exacerbation of asthma, I think the slide where your colleague show mild, moderate, life-threatening and whatever tu, it's very important, especially for moderate, severe and life-threatening tu, dia ada specific features that you need to memorize, because these are popular questions that can come out in your MCQs, your Viva, your essays, because these are something yang very specific, especially when you're talking about the PEFR. In reality, nobody really measures PEFR in acute settings, because the difficulty in measuring PEFR, because just imagine, kan, your patient just come in with acute exacerbation, gasping for breath, really anxious and really, oh, I want nebulizer because that's what they normally get, kan. Then suddenly you, okay, can you blow, close your mouth around this device and blow as hard as you can. You're making the patient do something that, for them, they feel that unnecessary. And to be honest, if you yourself in that acute situation, somebody asks you to do PAFR, you akan rasa macam, what's the point? Because the PAFR is not gonna give you relief. It may make your symptoms worsen. And it's especially worse if patient never done it before. And if you imagine, try to teach patient how to do PEFR while they gasping for breath. It's not gonna be a pleasant experience for you and for patient lah, because the patient's not gonna pay attention to you lah. So if you really want to do PFR, you really need to start teaching patient before they were having acute exacerbation. And patient just like you guys lah, kalau masa tu bukan tengah acute problem, you're not going to be interested lah. If not near the exam, you're not going to be really interested in reading books lah. So it's something like that lah. So PFR is something yang you need to mention in your exam, especially when you're talking how to differentiate between mild, moderate, severe or life-threatening asthma. But other features dalam table tu, specifically macam respiratory rate, dia punya how speak in words, phrases, the lung findings, saturation, CO2, PCO2 punya measurement, it's usually related dalam criteria of mild, moderate or severe lah. Okay, this is before we move on to treatment. Treatment, it's not that difficult because there's only few treatments. Yeah, if you read any whatever guideline, whoever's guideline pun, the treatment. Ya, cantik dah. Jangan kacau jap, dia buat kacau jap. So if you follow whoever's guideline pun, the management will be fairly similar, and the drugs used hasn't changed for the last, probably there's some slight change since the last 20 years, tapi it's all the same. So okay, let's move on to treatment.
So I'll be presenting on treatment. So the aim of treatment is to achieve rapid improvement of symptoms and prevent mortality.
So achieve rapid improvement of symptoms, prevent mortality is basically the aim of treatment for any disease lah, not just asthma lah. So this is a very general aim lah. Okay, so carry on.
So for oxygen.
Okay, so just go back. The aim of treatment for asthma is to relieve the bronchospasm. That's your ultimate aim of your treatment. Whatever treatment that you give, the aim is to relieve the bronchospasm. So it's not just improvement of symptoms. You want to really target the mechanism of treatment. And the issue in patient with asthma is bronchospasm. So your treatment is aimed at improving the bronchospasm.
Okay. So next will be oxygen. Pulse oximeter should be used to guide treatment if available. Absence of pulse oximetry should not delay administration of oxygen. Compared to controlled flow oxygen, higher concentration oxygen therapy results in significantly more hypercapnia in patients with severe exacerbations of asthma. So better.
Okay. So can you just go back to the previous slide? Sebab treatment for asthma, you really need to understand the principle. So treatment for asthma, the main issue with asthma is bronchospasm is the issue lah. Tapi the main issue with asthma, because of the bronchospasm, not necessarily oxygenation is an issue. What's the issue usually is ventilation. Patient can usually get adequate oxygen even in really bad asthma, tapi the issue is getting the CO2 out because of the bronchospasm. So kan, like I mentioned to you before, the problem with asthma is an expiratory. So inspiration usually not a big issue, tapi expiration and ventilation is a big issue. So usually you don't worry too much about oxygen, tapi your friend is correct. Initially you start oxygen for patient with asthma. Okay, carry on.
Okay. Next is beta-2 agonist. Inhaled beta-2 agonist relieve bronchospasm in acute exacerbation. Can be
Exacerbation.
Exacerbation can be administered via PMDI with spacer or nebulizer. In non-life-threatening asthma, there is no difference in lung function, such as peak flow and FEV1, length of stay in emergency department, and admission between spacer and a nebulizer for delivery of beta-2 agonist. In severe and life-threatening asthma, beta-2 agonist should be given via oxygen-driven nebulizer, 6 liters per hour.
Okay, so what these statements are saying, assuming that patient has perfect technique for MDI, there's no difference between MDI and nebulizer. However, if patient has poor technique, one way for you to alleviate the issue with poor MDI technique is using a spacer device. A spacer device kira made the necessity of good technique tu tak perlu lah. So if your patient has poor MDI technique, especially if they're children, advise them to use spacer device. You know what the spacer device is?
Yeah.
It kind of look like a hollow tube you attach at the end of the MDI lah. And patient, because if you want to use MDI directly, there's a specific technique kan. As you kena exhale dulu, goncang-goncang, put in your mouth, and as you press, you inhale. And then you hold your breath for a few seconds, then that's one. Then you have to do another one. And that sometimes it's difficult when patient is having acute exacerbation. And some people just don't have the hand-eye coordination kan to do that. So, or small children, very difficult to coordinate. So then you use spacer device lah. And spacer device has been proven to be effective even in elderly. So if your patient got really bad technique, ask them to use spacer device. And if you notice, masa COVID tengah peak tu, probably you tak notice kot, because masa COVID tengah peak, you guys semua kena study from home kan. So in our emergency department, when COVID was peaking, dekat asthma bay, we don't use nebulizer, because nebulizer generates particles kan, aerosol particle, and may increase the range of COVID punya spread. So what we use, we replace all the nebulizer dekat asthma bay with spacer device. So we give our salbutamol, our beta agonist, using spacer device for patient. Okay, the last sentence ni with regards to oxygen driven nebulizer for asthma, if you slightly give oxygen too much, it's not a big issue. Okay, so you can give oxygen driven nebulizer. It's gonna be slightly different in patient with COPD, but I'm sure we'll go into that later. Okay, carry on.
Next is beta-2 agonist dose. Suggested doses of salbutamol per nebulizer is 2.5 to 5 mg with maximum dose of 10 mg per hour.
Okay, don't worry too much about the maximum dose. If patient in acute exacerbation, sometimes you just give continuous salbutamol nebulizer or alternate salbutamol and ipratropium nebulizer. So the reason why in asthma we talk about MDI or we talk about inhaler, because we're aiming to deliver the beta agonist directly to where it's supposed to act. It's if you think about it, it's so much easier if salbutamol can give IV, and there are IV preparations of salbutamol. However, if you start giving IV or orally or parenterally salbutamol, the problem is that it causes other effects, other beta agonist effects everywhere else. You really just want to target the beta agonist effect on the lungs, because beta agonist effect is tachycardia that can lead to arrhythmia, palpitation and whatnot. So you really want the beta agonist to actually just go to the lung. That's why it's created in a way that you give it via inhalers and nebulizers, so that you actually inhale the thing and the thing acts on your lungs. Okay, carry on.
Okay, so the CBG recommendation, the nebulized salbutamol 5 mg repeat every 20 minutes for an hour.
Okay, that's recommendation lah. You follow or you don't follow, up to you. Okay, carry on.
For ipratropium bromide, indicated.
Ipratropium bromide.
Okay, ipratropium bromide, indicated in moderate to severe exacerbations of asthma in the ED or equivalent care setting. Addition of inhaled ipratropium bromide to beta-2 agonist for adults with acute exacerbation of asthma resulted in reduction in hospitalization, increase in spirometric parameters 60 to 120 minutes after the last treatment.
So basically, ipratropium bromide, it works synergistically with your beta agonist. Beta agonist works by stimulating the beta receptor lah, beta 2 receptors. Ipratropium bromide works in a different way. So tapi the end result is the same. It causes bronchodilation. So basically, by giving both ipratropium and beta 2 agonist, you are really targeting both ways to cause maximum bronchodilation as quickly as possible, because that's your aim. Your aim is to break the bronchospasm. Okay, so this basically what you're saying in the second last sentence is basically it helps lah. On top of just giving beta agonist, if you add ipratropium bromide, you get reduction in hospitalization, you get improved spirometric parameters quicker, okay, compared to just treatment with beta 2 agonist alone. Okay, carry on.
Next is the dose.
Okay.
Ipratropium bromide nebulizer is 0.5 mg every 4 to 6 hours.
You can give it a lot more frequent lah, but tak apalah. This is what the book says kan. Carry on.
So next is corticosteroids. Systemic corticosteroids should be given to all patients with acute exacerbation of asthma and continued for 5 to 7 days. Reduce inflammation in asthma, hence faster resolution of exacerbations and prevention of relapse. Asthma patients prescribed oral corticosteroids should continue their regular inhaled corticosteroids.
Okay, with regards to corticosteroids, we're talking about your prednisolone here, right? So, like I mentioned earlier on, the issue with asthma ni adalah chronic inflammation. And when you get acute exacerbation of asthma, you get acute inflammation on top of the chronic inflammation. So this is why steroid, prednisolone, have super important punya role in asthma. So any of your patient, when nanti you dah besar kan, start seeing patients apa semua, any patient that presents with acute exacerbation of asthma, you need to start steroid. You need to start prednisolone, be it oral or IV or whatever. You need to start steroid. and as soon as possible. And patient on exacerbation je, start steroid. And then the steroid should be continued for high dose. You're talking about 30 milligrams, 30 to 40 milligrams OD. Or for patient pediatric, 1 mg per kg. Acute, start. No need to macam, after second nap baru nak start. No. Any patient that presents with acute exacerbation of asthma, start steroids. High dose for 5 to 7 days. Then you can immediately stop. No need to taper down. Okay. For high dose steroid over a period of a week or so, you can just patient can just stop it lah. There's no need to wind down the steroid. No need to macam 30 turun to 20 for 3 days, turun to 10 for 3 days. No need. Tapi the main thing is you need to start steroid. The problem with steroid ni, it doesn't act immediately to reduce inflammation. It takes a good 3 or 4 hours before it has an effect. Okay, whatever effect that you see in the first few hours is usually related to your beta-2 agonist, your expiratory and whatnot. So steroid you need to start early because the effect is after a few hours. Because oral steroid or steroid in general needs to go into your cell nucleus, reprogram your DNA to express less gene for control of inflammation. Tapi you need to give it because it will reduce the inflammation. And like I mentioned before kan, the problem with asthma is chronic inflammation of the airways. So you need to reduce that inflammation and the airway will become, wider lah, rather than become narrower kan. So steroid is very important. You need to start, okay, very early on. So I'm not sure whether are you going to be talking about inhale corticosteroid tak? Macam what do you call it? Budesonide. Tak ada.
No.
Tak ada. Okay. So the other advancement lah, the latest advancement in management of acute asthma in the last 10 years is inhaled budesonide, or nama glamour dia Pulmicort. Pulmicort is inhaled corticosteroid. Okay, budesonide is not something new. It has been in the market for the last 20 years. Tapi in the last, I think 5 to 6 years, people to start to realise the importance or the benefit of inhaled corticosteroid in management of asthma. Because I mentioned before kan, oral steroid or IV steroid, the steroid needs to circulate in the blood, masuk dalam nucleus of the cell and bagi instruction to your nucleus to express the appropriate genes, whether to suppress inflammation and whatnot. So that takes hours. So with inhaled corticosteroid, the steroid you inhale and directly acts on the target organ lah, which is the lung. So they reduce the inflammation of the airways much quicker and much more targeted. So I think if you find, I mean, it's not gonna be in the CPG just yet, but if you go to nanti kat medical ke, kat pediatric ke, you will realise that people are start to incorporate budesonide or Pulmicort in the early acute management of asthma, because the studies has proven that it has significant benefit lah. That's probably something that you want to talk about, because we want to read around about lah, usage of inhaled corticosteroid in acute exacerbation of asthma. Because previously, inhaled corticosteroid are mainly used as preventer, kan, for management of stable asthma. Okay, so this is on top of your systemic corticosteroid lah. Okay, carry on.
So for the dose for corticosteroids, for IV hydrocortisone is 200 mg, and to start immediately. Insulin 1 mg per kg to a maximum dose of 50 mg for about 5 to 7 days.
This 1 mg per kg usually applies for pediatric patient lah. For adult patient, normally, very rarely lah, for asthma, kita start steroid at 50 mg. It's usually 30 to 40 mg lah, OD for 5 to 7 days. So 1 mg per kg ni usually refers to pediatric patients. Okay. Carry on.
So next is magnesium sulfate. IV magnesium sulfate is indicated as an adjunct in acute, severe, and life-threatening asthma. In acute exacerbation of asthma not responding to initial treatments, intravenous magnesium sulfate significantly improve pulmonary function and reduce hospitalization.
Okay, so IV magnesium sulfate, this has started to become popular in the last 15 years because studies about using IV magnesium sulfate in acute exacerbation of asthma only start to become popular about 15 years ago, and it does work. So it's very important for you to recognize very early on whether your patient ni moderate, severe, or life-threatening asthma, because in life-threatening asthma, or even in moderate to moderate or life-threatening asthma, or moderate, severe, or life-threatening asthma, you really want to start your magnesium sulfate early, because it has been proven that by giving magnesium sulfate early, you reduce risk of intubation, and you cause improvement to be much quicker. Okay, so this is very important. So that's why it's important to be able to recognize whether your patient is mild, moderate, or severe, or life-threatening asthma, because it will help you to decide what to start or when to start medication. Okay, carry on.
So for the dose for magnesium sulfate is 1.2 to 2 gram infusion over 20 minutes. For mechanical ventilations, patients with critically unstable asthma should be intubated early and referred to critical care. Next, I'll be presenting on monitoring and evaluation. So this is peak expiratory flow, measurement of airway caliber, expressed as a percentage of the patient's previous best value or percentage of predicted. Measurement will determine severity and treatment. Next is oxygen saturation, measured with pulse oximeter to determine the adequacy of oxygen therapy. It is best to maintain SpO2 at 94 to 98%. Next is arterial blood gases, ABG, assessment of pH, level of oxygen, and carbon dioxide from blood via direct arterial puncture, to be performed in life-threatening asthma or SpO2 less than 92%, irrespective of whether the patient is on air or oxygen. SpO2 less than 92% is associated with a risk of hypercapnia, which is not detected by pulse oximeter. Next is chest radiograph, recommended in patients with suspected pneumothorax or pneumomediastinum, suspected consolidation, failure to respond to treatment, life-threatening asthma. Next, I'll be talking about critical care admission. So it is early referral for critical care should be considered for asthma patients who respond poorly to optimal treatment and at risk of respiratory failure. Consider critical care admission for patients with deteriorating PF, persisting or worsening hypoxia, hypercapnia, ABG analysis with worsening acidosis, exhaustion, drowsiness, confusion, or altered conscious state, respiratory arrest.
Okay, so before we go to COPD, key point about asthma is the aim of the treatment is to break the bronchospasm. Okay, so treatment should be ada guideline lah, dia ada step by step punya treatment. If you go to any sort of emergency department or specifically kat asthma bay, you can find sort of algorithm, you know, first patient datang, what you need to do, then the first treatment is what, second line treatment is what, nah. So dia ada step by step care lah. And patient asthma, it's very important for you to treat asthma properly because it's something that is reversible. Asthma, kalau you tanya, you know, when you start working nanti tahulah, asthma is a type of disease or patient yang ada asthma ni shouldn't die because of asthma. At least not in this day and age. Okay? Because if patient with asthma dies, maksudnya there's some substandard care or some mismanagement there, because by whatever definition, asthma is something yang reversible. So if patient with acute exacerbation asthma dies, maksudnya either the patient present too late to hospital or there's some problem with your management in hospital. Okay? Remember, asthma, it's reversible. Patient with asthma shouldn't die if you treat them properly. I mean, that's what we say lah. But, you know, the Almighty is more powerful kan. When, you know, He decides somebody is supposed to die, He die lah. But secara principalnya, patient with asthma shouldn't die, especially once they reach the hospital. Okay? So, okay, let's move on to COPD.
So the definition of COPD is chronic obstructive pulmonary disease is a preventable and treatable respiratory disorder largely caused by smoking. It is characterized by progressive, partially reversible airflow obstruction and lung hyperinflation with significant extrapulmonary and systemic manifestations and comorbid conditions, all of which may contribute to the severity of the disease in individual patients.
Okay, remember the definition, tengok definition, the key thing where with regards to the definition of asthma and COPD is asthma is a completely reversible airflow obstruction, while COPD, it's partially reversible because it's something that causes structural changes to your lungs. So it's partially reversible. If you don't remember anything else, remember asthma is fully reversible, COPD is partially reversible. Okay, carry on.
Okay. Next will be the diagnosis and assessment. So a diagnosis of COPD should be considered in any individual with symptoms of chronic cough, sputum production or dyspnea, and a history of exposure to risk factors for the disease, especially cigarette smoking. The diagnosis should be confirmed by a spirometry showing a post-bronchial dilator FEV1/FVC ratio of less than 70%.
Okay, what's FEV1? What's FEV1? How do you check for FEV1?
FEV1 is
What does FEV1 stands for? Anyone else can? Anyone can also help Lynette?
forced expiratory volume in 1 second.
No. The forced expiratory volume tu betul dah. The 1 second tu wrong.
Oh, okay.
What is it? One what?
Is it how much air you can exhale in 1 second?
Not 1 second. Why are you obsessed with 1 second? It's 1 minute.
Oh, okay.
Forced expiratory volume at 1 minute. For 1 minute. Have you ever seen people doing spirometry?
Not a real life thing. I haven't seen in real life, but then only just.
Okay, so basically spirometry ni is, if you ever seen a picture of it lah, patient blowing through a tube lah. It's like you know your recorder masa your primary school tu. It's basically if you spirometry ni, it's like blowing through a recorder connected to some computer lah. So basically FEV1, what you ask the patient to do is to blow as hard as they can for 1 minute. That's your, so patient will be doing like that. So that's your FEV1 ratio. FEV1. That's your FEV1 reading. FVC is full vital capacity. So blow, so patient, in the beginning ask the patient to blow as hard as they can for 1 minute. FVC is you ask the patient to blow for as long as they can until they really ran out of breath. That's the full vital capacity. So then you get you plot your FEV1 over your FVC and you tengok ratio dia. If the ratio is less than 70%, then it means that your patient ada obstructive lung disease. For patient with normal lung or with restrictive lung disease, the FEV1 over FVC ratio is more than 70%. The ratio will remain the same regardless of patient tu ada, if patient has normal lung or restrictive lung disease. What changes with restrictive lung disease is the FVC tu yang akan kurang. Nanti you baca lah pasal spirometry. This is also quite important. At least masa dalam exam lah dia akan keluar. Bila dah kerja nanti, unless you work in a respiratory punya unit, nobody will care lah. Okay. But for at your level, your understanding, you need to understand FEV1, what's FEV1, what's FVC, FEV1 versus FVC ratio in obstructive versus restrictive. They sometimes in your exam they ask you to draw the graph tau. The graph of FEV1 versus FVC ratio for obstructive disease, FEV1 FVC ratio for restrictive disease. So you need to be able to draw the graph, because this is quite important for your exams lah, especially. Okay, because for at your level, they don't just want you to know the management. I mean, because the management is easy, because it's the same thing for the last 20-30 years. Tapi the pathophysiology, it's very important. These are exam questions lah. Okay, and the graph, you need to be able to sort of draw the graph for restrictive versus obstructive punya lung disease. Okay.
Okay, Doctor. Diagnosis of COPD should be considered in any individual with symptoms of chronic cough, sputum production, or dyspnea, and a history of exposure to risk factor for the disease, especially cigarette.
Okay.
Wait.
So this one it's okay je. COPD and asthma presentation is similar. Cuma you have to look at clinical picture lah. Maksudnya asthma tend to present in younger age group, sometimes with no history of smoking. If patient in their 50s, 60s yang previously has no asthma suddenly present dengan asthma, you really need to consider whether they actually have COPD. Okay, carry on.
So COPD severity should be assessed based on the severity of spirometric abnormality, symptoms, exercise capacity, complications, and the presence of comorbidities.
Habis dah COPD?
Belum. The next person will be.
Sure.
Oh.
Okay, come on, carry on.
She got the wrong file, so she has to wait.
No worries. I've got all day. Luckily, plan buat online. Suddenly, I kena HSO hari ni. My wife punya swab turns out to be positive. Sambil tu, okay. So, sambil we're waiting for your friend to get your slide ready. COPD ni, traditionally, it has been divided into two lah. Have you heard about pink puffer and blue bloater? You guys heard about pink puffer and blue bloater tak? Because traditionally COPD ni has been described into two pathophysiology lah. One clinical, one is a clinical punya diagnosis, blue bloater, and the other one pink puffer is a pathological punya diagnosis lah. So with the blue bloater, the clinical criteria to diagnose COPD is patient having persistent productive cough for I think more than 3 times per year over a period of 2 weeks or something like that. So that's a traditional clinical diagnosis of pink blue bloater. You know, the sort of patient that, you know, dia ada barrel chest, look cyanose and nampak very bloated kan. And then there's the pink puffer is a pathological diagnosis where you ambil biopsy of the lung, you look under microscope, you'll see a permanent dilatation of the alveoli. So instead of your small alveoli yang macam grape small tu, your alveoli become huge. And on X-ray, this is classical emphysema lah. So the pink puffer is COPD yang because of emphysematous changes to the lung. However, as more research has been done, as we learn more about COPD, we all realize that there's no hard separation between pink puffer and blue bloater, or there's no just chronic bronchitis. There's no COPD yang purely chronic bronchitis, and there's no COPD yang purely emphysema. Usually it's a mixture of both lah, and blue bloaters tend to have more chronic bronchitis element, while the pink puffers has more chronic emphysematous punya changes to their lung lah. So nowadays emphysema and bronchitis, chronic bronchitis ni is grouped in the same umbrella, under the same umbrella of COPD. Okay, so okay, good. Yang stage COPD ni, I think, is it based on the gold punya CPG ke? Gold punya guideline ke? Ke Malaysian punya guideline?
It's a Malaysian one, I think.
Okay, Malaysian one also copy and paste from gold lah, so don't worry too much about it. Okay, so what's important for you is this MMRC scale, MMRC 1, 2, 3 and 5 lah. Up to 5. MMRC dia ada MMRC 1, 2, 3, 4 and 5. So it's pretty similar to NYHA classification of heart failure. Okay, cuma MMRC punya classification is more for pulmonary diseases punya issue lah. You can remember it by, you know, grade 1 minimal symptom, grade 2 symptoms of minimal exertion, grade 3 symptoms on moderate exertion, grade 4 symptoms on very minimal exertion, and again grade 5 symptoms at rest lah, something like that. It's something that's useful for you to see progression of your patient's disease, and also for you to communicate between your colleagues lah. Because this is the functional condition of your patient. Okay, carry on. So macam mana, masih tak jumpa slide ke macam mana?
Dia punya line terlalu weak, tak boleh share dekat.
Okay,
I try pun tak apa. Just now can see doctor.
Can see? I mean I can see lah.
Oh, okay.
Next, I'll be presenting on the classification of COPD severity. The COPD stage, there is stage 1, 2, 3 and 4. The first one, the severity is mild, and based on the classification by post-bronchodilator spirometric values, the FEV1 over FEV is less than 0.70, and the FEV1 is more than 80% predicted. Based on the classification by symptoms and disability, the person should experience shortness of breath when hurrying on the level or walking up a slight hill. The second stage, the severity is moderate, and based on the classification by post-bronchodilator spirometric values, the FEV1 over FVC is less than 0.70, and the FEV1 ranges between 50% to 80%. The classification by symptoms and disability is the person will walk slower than the people of the same age on the level because of breathlessness, or stop for breath after walking about 100 meters or after a few minutes at own pace on the level. The third COPD stage is stage 3, which the severity is severe. Based on the classification of the post-bronchodilator spirometric values, the FEV1 over FVC is less than 0.70, and the FEV1 is between 30% and 50%. The classification of symptoms is full breathlessness to leave the house or breathless when dressing or undressing. The last COPD stage is stage 4, where the severity is very severe. The classification by post-bronchodilator spirometric value is FEV1 over FVC, which is less than 0.70, and FEV1 below 30% predicted or below 50% predicted, plus with chronic respiratory failure. And the classification by symptoms and disability is presence of chronic respiratory failure or clinical signs of heart failure. Next will be the management of acute exacerbation of COPD. The aims of the management and exacerbation of COPD are to relieve symptoms and airflow obstruction, to maintain adequate oxygenation, and to treat any comorbid conditions that may contribute to the respiratory deterioration or treat any precipitating factor such as infection. Some of the indications for hospital assessment of admission of acute exacerbating COPD are marked increase in intensity of symptoms such as sudden development of dyspnea, underlying severe COPD, development of new physical signs such as cyanosis and peripheral edema, hemodynamic instability, reduced alertness, failure of exacerbation to respond to initial medical management, significant comorbidities, newly occurring cardiac arrhythmia, older age, and also insufficient home support. Next week, I will be presenting on the home management. First, a patient with acute exacerbation COPD and has to obtain the relevant history such as underlying COPD severity if it's known, comorbidity, and present treatment regimen. And if they do have any indication for hospital assessment or admission. Some of the indications for hospital assessment or admission are, as I mentioned just now. So, and then it will be divided into two for none and if they do have the indication for hospital assessment or admission. For a person without hospital assessment or admission, they will be administered in inhaled short-acting bronchodilator from PMDI via a spacer device or nebulizer depending on the severity. And it depends. If the response is good to the treatment, they will be discharged with follow-up and check inhaler technique, arrange appropriate investigation if this is a new presentation, and refer to the specialist if necessary. For home management, we will increase the dose and frequency of inhaled short-acting bronchodilator and prescribe them with oral prednisolone or oral antibiotics if patient has 2 out of 3 cardinal symptoms. If the person has to be admitted, first we will administer initial treatment such as inhaled short-acting bronchodilator, oral prednisolone, start initial dose of antibiotic and supplemental oxygen therapy if saturation is below 90%, and we will refer to the nearest hospital or the patient's usual hospital.
Carry on.
Next is hospital management. First, has the same as above. The patient will be presented to the ED with an acute exacerbation COPD. Then we obtain the relevant history such as current symptoms, recent treatment from other doctors, COPD severity, previous episodes such as acute exacerbation COPD, hospital admission, ICU admission, invasive or non-invasive ventilation, examine for danger signs such as respiratory distress, tachyarrhythmia, cyanosis, heart failure, and exhaustion. Some of the investigations that will be done would be ABG, full blood count, and then LFT, blood glucose, chest X-ray, ECG, and system test. Then it will be administered with the initial treatment, which is controlled oxygen therapy, inhaled short-acting bronchodilator, oral prednisolone, and also start with antibiotics. And if the patient responds to the treatment, then there will be no indication for hospital admission. The patient will be discharged with follow-up, have their inhaler technique, and refer to the specialist if this is a new presentation. The home management will be to increase the dose and frequency of the inhaled short-acting bronchodilator, prescribe them with oral prednisolone, and to ensure adequate supply of oral antibiotic is started. If the patient fails to improve, the patient will be admitted to hospital, and in the hospital management, we will give controlled supplemental oxygen therapy to maintain the oxygen saturation, without worsening the hypercapnia or precipitating acidosis, inhaled short-acting bronchodilator, consider intravenous aminophylline if inadequate response to inhaled short-acting bronchodilator, systemic corticosteroids, antibiotics, monitor the fluid balance and nutrition, consider subcutaneous heparin, closely monitor condition of the patient, and also consider invasive or non-invasive ventilation.
Okay, this slide is fairly important for you to know the difference between COPD and asthma, because this is also favorite question that come up in the exam.
Lastly, I'll be presenting on the differences between asthma versus COPD. A person with age usually below 45 and has a history of atopy is frequent to get asthma, while a person who is age usually more than 45 and usually people who smoke about 20 packs per year are usually prone to COPD. The symptoms in asthma would be cough, dyspnea, wheeze, chest tightness, and maybe asymptomatic between exhalations. While for COPD, the symptoms will be cough, dyspnea, symptoms of right heart failure, and it's usually symptomatic between exhalations. In examination for an asthma patient, usually it will be normal is between exhalations, while for a COPD patient, it will be decreased breath sound, hyperresonance, hypoxemia or synosis, barrel chest, first lip breathing, and also subcapsoid PMI. In PFT findings for an asthma patient, the variable abnormal spirometry, the FEV1 over FVC will be less than 70%, scooped out expiratory flow volume curve, low peak expiratory flow, improvement following bronchodilator, and spirometry often normal or near normal between attacks. While for a patient with COPD, it will be persistently abnormal spirometry, which is FEV1 over FVC will be less than 70%, and modest improvement following bronchodilator can be present.
Dia dah buka pamper, Sophia. Sophia, dia buka lampu. Okay, finish? Finish? Okay, so the other important difference between COPD and asthma is that with patient with COPD, you can't give them too much oxygen. Traditionally, this has been explained by theory of hypoxic drive. You've heard of hypoxic drive? Patient COPD, dia ada chronic CO2 retention, so the chemoreceptor in the blood-brain barrier has reset to higher level of CO2, and then so they breathe, dia punya respiration center is dependent on dia punya hypoxic drive to ensure patient, increase respiratory rate or not breathing dan sebagainya. Have you heard of this? This hypoxic drive punya teori ni? Hello?
I'm not sure, doctor.
Not sure. Okay, so one of the issue or benda yang selalu orang cerita pasal COPD ni is you can't give them too much oxygen, because in the way our respiration is controlled by our midbrain ni, it's usually based on CO2 level, PCO2 level, because carbon dioxide is the thing that crosses the blood-brain barrier, and our midbrain, dia ada chemoreceptors to CO2. So if you have high PCO2, your brain will stimulate you to hyperventilate, to wash out the CO2. And if you have low CO2, then your brain say, okay, you can breathe normally, or slow down your breath so that you wash out CO2. So this is the physiological mechanism on how our brain control our breathing lah. So if you have high CO2, means that you need to breathe, either you're producing more, or or you have high CO2 lah. So if you're running a marathon and suddenly your body start to build up CO2 and everything, your brain will tell you, okay, now you need to breathe more to wash out the CO2. Okay, that's how our respiratory rate is controlled by our midbrain. However, with patient with COPD, they chronically have higher CO2. So once your brain start to detect, oh, okay, this person always have high CO2, so they said mungkin this high CO2 is normal for him, so your chemoreceptors reset its threshold. So it say, okay lah, if the CO2 goes above certain, kalau previously the CO2 level punya threshold is set at 30, so if the CO2 goes more than 30, they'll tell your lung to, okay, hyperventilate now. Okay, now since you have chronically high CO2, your chemoreceptors in the brain sort of resets itself and says, okay, now the threshold level is 50. Unless the CO2 goes more than 50, you hyperventilate. Unfortunately, this causes hypoxia, because selagi CO2 tu tak sampai 50, then your brain will not tell your lung to breathe more kan. So what does this do is you become hypoxic. So then bila you become hypoxic, you've got another level of chemoreceptor yang detect, hypoxia ni. So then they detect hypoxia, okay, now you need to breathe because you're hypoxic. Okay, this has been the traditional belief on how our respiratory system works. What they realize, but now based on more research and study, what they realize that this is not an entirely accurate punya assessment on how our respiratory system works. The new theory is why we cannot give too much oxygen for COPD patient is this hypoxic pulmonary vasoconstriction punya theory. This relates to ventilation perfusion of the lungs. So in this theory, what you need to understand is our lungs, or not our lungs lah, patient with COPD, they have lungs there are parts of the lung yang dah rosak, and there are parts of the lung yang okay, yang boleh berlaku gaseous exchange. Okay, so part of the lung yang rosak, your pulmonary arteries, dia tahu, oh, this bottom part of the lung rosak, so they purposely vasoconstrict, because that part of the lung hypoxia, dia rosak, there's no gaseous exchange, no oxygen goes there, so they vasoconstrict dekat kawasan yang rosak tu, so that they can divert the flow to area where gaseous exchange can occur. However, this sort of compensatory mechanism for patient with COPD, because they got parts of the lung yang tak berlaku gaseous exchange kan. Tapi when you give them too much oxygen, the higher oxygen causes all the pulmonary arteries to vasodilate, because previously they vasoconstrict because of hypoxia. Now because there's so much oxygen going around, so the parts of the pulmonary artery yang vasoconstrict before vasodilates. So now you got perfusion to the whole lung, both bahagian yang ada gaseous exchange that occur, and also bahagian yang tak ada gaseous exchange occur. So this leads to ventilation perfusion mismatch, and paradoxically worsen the patient lah. You think by giving more oxygen, this patient will get better. Tapi unfortunately, by giving more oxygen, you make the patient worse. So it's not an easy concept to get or to grasp lah in just one session kan. So do go read up. I mean, I don't care whether you baca on the internet ke, you baca dalam textbook. Look for hypoxic pulmonary vasoconstriction and just read up about that, and you'll understand why patient COPD, it's not a good idea to give them too much oxygen to start with. Okay, any questions? Or am I just have I just been rambling and you tak faham apa-apa? Tapi take home message, asthma reversible, COPD not reversible, and read around hypoxic pulmonary vasoconstriction. It may come up in your exam. Okay, any questions? Tak ada questions?
No, doctor.
Tak ada questions, then okay lah. Bye-bye.